Hello, I'm Stephen Boone. We are doing our Build a Patient, and let's go and begin. I'll do a quick tour of the skeleton, and just go ahead and pull this off. So what I did is I taped um, all the signs and symptoms where they would happen. So right here I have agitation, loss of track of time, shaking, very angry. There I put the vital signs. And then right inside the thoracic cage, you can see the heart and the lungs. And then here on the hand, that's where the clubbing's at. So, what we have is an older patient that has asthma and is exacerbated. She comes into the ER, brought in by a family member. The family, and she's annoyed with the family member, and she's really agitated as a person. Her vital signs: 142 over 88, pulse of 114, respirations 32, O2 sat at 84% at 2 liters nasal cannula. And then you can audibly hear wheezing from her lungs. And because she has a clubbing, she's probably going to have a condition with her heart. We're not sure yet at this point. And then she has clubbing on her hand. Sorry, it's all taped there because I did not want to color on my skeleton. So she would have blue lips, cyanosis. Her capillary flow is between 3 to 4 seconds. So let's go ahead and dive in. We decided that we are going to treat the patient with turn up the oxygen up to 4 liters per minute. Use a corticoid steroid, but we have to be cautious with using those because she has a history of diabetes and steroids raise blood sugars. However, in this case, considering that her breathing is compromised, it's worth the risk. We're going to go ahead and get a blood glucose to monitor for that. She might get some insulin. She will take her albuterol at the same time because you can use both of those as a combination and it's really effective. So after the fact, I would expect that her oxygen would go up, hopefully to above 90, and that would be good because I can continue the rest of the assessment. I would expect her to take better breathing. Right now she's taking really shallow breaths. It may not make it below 20, it might, who knows, but I would expect deeper breaths, less use of accessory muscles. The blood pressure and pulse should go down because they won't have to compensate so much anymore. I should not be able to auscultate wheezing anymore. It said in the note that I can auscultate it without a stethoscope, so hopefully this time I would need a stethoscope to test. But I still don't want to hear it either way. We'll get a chest x-ray done just to make sure that there's no other concerns. One of the concerns that could happen is potentially lung cancer, and that could cause something in there. We just got to rule everything out. For labs, when we got those draws, I'm going to check for ABG for any respiratory acidosis, checking her eosinophils, making sure that they're not greater than 4%, but they probably are. I can see the bronchial wall thickening if I did an x-ray. Electrolytes could show signs of hypomagnesia, hypokalemia, hyponatremia, and hypocalcemia. Her glucose will probably be elevated, especially after the use of a steroid. And she probably, pulse is over 100, so she would have sinus tachycardia. So in her medication, it says that she was taking Lexapro, which is used for depression, and she says she's not taking that, so I would definitely want to consult a social worker or an expert on that. Also want to consult respiratory therapy to see if that can help. Figure out why she's not taking the Lexapro. Maybe she feels it doesn't work, maybe she feels it's not necessary, or maybe she can't afford it. So that's where the social worker comes in to figure out what our options are from there. Want to ask more past history questions because she could have COPD, or she could have been a smoker. There are people that have asthma that also smoke. It does happen. and maybe she's had a heart attack or at some point. We don't know, but I really want to figure out why she's having clubbing in her fingers. Why does that relate? Because normally asthma and clubbing don't mix. There's normally something else going on. Radiology, of course, to see the lungs, see if there's no fluid buildup, no evidence of pneumonia, no other concerns. Most of these tests will probably be done with the respiratory therapist, but we can do the spirometry, a PEF, and a nitrous oxide test to see, and that type of stuff typically proves that it was in fact asthma. Bronchodilator, responsive test, and that one can be useful to see if her medications were working or not. And other labs to order, of course, the ABG we already went over those. Yeah, we went over that part. Okay. So other medications that could be possibly prescribed is if the Lexapro is not working, she might get sertraline or Wellbutrin. I would caution against tiredness, insomnia, dizziness, diarrhea. There's a whole plethora of side effects, but those are more common ones. Possibly buspirone to control anxiety. That could be, and the possible side effects are headaches, nausea, dizziness, anxiety, drowsiness, disturbed sleep, and xerostomia. And then possibly Singulair, which is a LABA, but it's not a steroid, so it won't raise her blood sugar, and that takes into account her diabetes. So once we get her stabilized, we'll do a pulmonary function test, low-dose computed tomography, and that's what we're going to use to check and see if she has lung cancer or not, because that is a possibility as to why her asthma is not controlled. We just got to rule it out. Also do a GAD-7, which is an anxiety check, see if she does have anxiety or not, or if it's just an acute episode. And then the PHQ-9, which is a depression test, and again, that could be used to determine if her medication is effective or if it's not, and see what needs to be changed. If she gets a nosocomial pneumonia infection, we would use vancomycin. That is pretty standard for that. If not, her discharge instructions are to stay hydrated, 8 cups of water a day, use albuterol before exercise or outdoor activities as a preventive, keep her inhaler on her at all times because that's what exacerbated this episode. Take medications as prescribed because there's a history of non-compliance. And if she is smoking, no more smoking. And no long-term unnecessary exposure to aggravating environments. So that's what we got, and we're hoping that'll help. That's pretty much it.